And now we have another stalwart in phacosurgery, Dr. DEEPAK MEGUR, and he's going to talk on subluxated lenses, how to handle subluxated lenses. Over to you, Dr. DEEPAK.
कनेक्टर है चेक करो आ रहा है कि नहीं Dr. Bide, thank you for the opportunity. Dear friends, I'll be speaking on management of subluxate cataracts, and the theme of the session is what will you do for this case. Now, he's a 65-year-old gentleman who presented with this intermittent cataract, but also has this 4 o'clock hour zonal dehiscence in this. So we have got multiple challenges to deal with. The first would be obviously, deal with the zonular loss part, and second, the rexis issue as well. The first thing always is, before you even do or touch the anterior capsule, is always try to rule out the presence of vitreous in such eyes. And diluted triamcinolone staining confirms that there is a transzonular migration of the vitreous, which needs to be dealt with first before even touching the anterior capsule. So with the irrigation bimanual anterior vitrectomy, you take care of the prolapsed vitreous. I'm using cohesive OVD to ensure that the chamber is maintained and I can get my rexis right. The most important step in all subluxated cataracts is to get the rexis right, because if you get the rexis right, then you can use all the capsular bag stabilizing devices. So because I could get the rexis right, I am placing my capsule hook in that segment, and I'm going to support the bag by using CTR now itself. The idea is, when you stretch the bag, the CTR is placed in such a way that the zonular weakness is supported first, so that there is no worsening of the zonular tear which is already existing. Another reason why I'm placing the CTR early is it also provides an equatorial expansion, which minimizes the migration of the fluid across the zonules into the vitreous, which can cause fluid misdirection. So you're always going to replenish with OVD and try to ensure that the vitreous is not prolapsed yet. And if it is prolapsed, again go back and remove the vitreous before going into managing the nucleus part. So only greatest virtue one has to have is patience in such cases. You have to be very patient. And the white plaque what you're seeing is actually the triamcinolone which is migrated behind the posterior capsular bag. So we need to remove that, and in this situation I am going to do a pars plana anterior vitrectomy. The irrigation is going to be through the anterior root itself, but I am going to manage the prolapse, transzonular prolapse of the vitreous. I want to deal with it by using the pars plana approach. Care is to be taken that we don't perforate the posterior capsule in this situation. So we have a CTR in the bag, and in this case, of course, you could have always gone ahead and put it in the bag itself, but here I'm trying to achieve the optic capture and try to have an IOL trap technique. The patient is old and maybe having a little bit of a pseudo exfoliation. That's the reason I put, but you can always go ahead and put it in the bag itself. Always ensure that before closing, the eye is totally free of vitreous, and whenever you do vitrectomy, try to ensure that all the wounds are watertight and sealed. So these are the post-operative outcomes of this patient, and they usually are they do very well. Now moving on to the next scenario, which is very commonly which we see, that is pseudo exfoliation and generalized zonular weakness. This is probably every 4th or 5th case in the list will be like this. You have the extra space between the iris and the lens, suggestive of a generalized zonular weakness. When we touch the capsule, the wrinkling of the anterior capsule again indicates there's a generalized zonular weakness. And these are the situations where either you have to fix the bag using two segments if it is very significant, or you have to compromise the bag. So got multiple options available here. Either you have to save the bag or sacrifice the bag and put a scleral fixated lens or an iris claw lens. But in situations where it is not so dramatic, so not so worse, maybe a moderate density, which I shown here, you can still salvage the bag and maybe fix the lens in a slightly different way. The traditional way has always been put the CTR and the IOL both in the bag. But the one issue is, there's always a tendency for late dislocation and decentration, apart from the massive pseudophacodonosis which we see. So I've been using this IOL trap technique for some time now, maybe for the last 6-7 years, where the CTR is placed in the bag and we place a multi-piece hydrophobic lens in the sulcus with an optic capture. So let us try to understand the principles. The first thing when we manage a pseudo exfoliation case is to ensure that we are seeing well. And you can use an iris hook or a BX device. My go-to device has been the BX device in these situations. It does a pretty well job in most of the situations for pseudo exfoliation. The most important thing is to get the rexus right and its sizing right, because if you're aiming for an optic capture, you cannot have a rexus which is more than 5 millimeter. It has to be at least 5 millimeter or 4.5 to 5 millimeter. Hydrodissection is probably the very important step here, because before we venture into nucleus management, we want to ensure that the cortex and the nucleus are truly away from the capsular bag. And early insertion of CTR is a very critical thing in my practice. I always prefer to use this. Well, there is always an option of using 4 capsule hooks as well. But once if you're able to put in a CTR early enough, I can avoid making those extra 4 incisions. That is a reason why I prefer to use the CTR. And then obviously the phacomulsification, usually these patients are elderly, the nucleus will be dense. You will have to be having a very controlled way of managing this nucleus. The nucleus division technique of your choice will do the job, but only thing is you need to ensure that you're in good control. Cortex aspiration with the presence of a CTR can be challenging, but if you use the tangential method of stripping, it is not going to be a major issue at all. Again, you can use the bimanual to retract the iris along with the BX hook, and then see that you're under direct visualization. You can actually strip the cortex around the CTR itself. This is the step where most commonly people get scared and are of losing the bag, but if you're careful, it can be done. The final step would be to put the multi-piece hydrophobic lens into the sulcus here. So we are removing the OVD behind the lens and in front of the lens, and then with the irrigation cannula in my non-dominant hand, I'm pressing the IOL back into the capsular opening so that I get the ovalization of the rexus. This indicates that we have an adequate optic capture. So this is the way we stabilize the lens. Now, this is another case where patient has very complex pathology, like non-dilating pupil, compromised zonules, and the zonular health can be assessed only once you touch the capsule. So I'm trying to mobilize the nucleus after doing hydrodissection. You can see that the entire bag is moving. So you may not have sort of phacodonosis at the slit lamp, but actually start handling the lens, you really know how bad is the situation is. So you have a generalized zonular laxity here. So one trick here to put the ring early when you have such a swollen lens is that you need to create some space. I aspirated a little bit of cortex and I'm using cohesive OVD under the anterior capsule. That creates a little bit of a space for us to easily negotiate the CTR into the bag here. So here you have a 360-degree zonular laxity here. So once we put in the ring, we are provided with that support. And of course, the nucleus management is going to be standard technique. And once you're done with it, you are going to achieve this optic capture. So this is how the eye is going to look in this. So this is, in my opinion, the best way to deal with the eyes with pseudo exfoliation with long term. We're expecting it's a progressive phenomenon. So basically, what we're thinking that the lens itself is supporting the bag rather than the other way around. So the lens is supporting. I have a reasonable experience of most 6 to 7 years now. And this has been the thing. Primary benefit, obviously, the centration stability is better. But one secondary benefit which I have noticed is the reduced incidence of pseudophacodonosis in these eyes. So the principle here is, you are getting an equatorial expansion, 360 degrees expansion by the CTR, which is in the bag, and the hydrophobic lens in the sulcus. Basically the haptic in the sulcus and the optic is pushed back in the rexus. This sort of redistributes the weight around the capsular bag complex, and this ensures that actually the lens is somewhat holding the bag. So of course the time is going to tell us how long it's going to stay there, but this is one way of trying to deal with these eyes, with a very common scenario of eyes with pseudoexfoliation and generalized zonal weakness. So two things are very critical. One thing is we have to get the rexus right, which is well centered, and hydrophobic lens is important because we can see this fibronectin secretion on the capsule, which actually ensures that the lens is sticking onto the capsular bag. So this is what is important. This we can't achieve with an hydrophobic lens. So multi-piece hydrophobic lens is important rather than hydrophilic, and this is what ensures probably that the lens will be holding the bag for some time to come now. So moving on to the next case scenario, the next case scenario would be like where we are going to not able to save the bag in extreme cases of zonal adhesions. Like this case, this is microspirophakia in a very young patient, and obviously it is too compromised to attempt any sort of a bag salvaging procedure. We have an option of doing a scleral fixated lens, or the other easier option of putting an iris claw lens. So of late, maybe 3 years, we have shifted more to the iris fixation the lens, and this I'm going to demonstrate one such case of an iris claw lens in this patient. So here the aim is to deliver the nucleus in a very traumatic way. We obviously know that there is a subluxation, and there is also the vitreous is already probably disturbed, so as was evident in the slit lamp picture. So once we create we are creating the scleral tunnel of adequate size. Is about 6.5 millimeter. Now for iris clip lens, as we all know, it comes only in PMMA rigid lens. So when making the side port incisions for fixation, this is extremely important that we just mark it and then use a very short tunnel. So it has to be very short. We don't want to have any tunnel here. So direct stab entries would be much more easier for us to do the enclavation part. Now in this case, I'm just going to do an visco expression of this case rather than using any instrumentation. So you don't want to drag the vitreous in these eyes. So what we are doing is just going to use, there is no vectis or anything. Just we are going to use viscoelastic under the lens, and it's just going to express it out. So this is probably a very traumatic way of dealing with the nucleus here. And this patient is relatively young. The nucleus will not be very high. Of course, this is a case of a spirophakia. And once it is done, you need to ensure that before putting the intraocular lens implant, take care of all the prolapsed vitreous. So the common question which is always asked to me is that on the outset, the iris claw lens appears to be very easy. Can we do it without a vitrectomy? I think the most reason why most of the lenses get a bad name because we don't do a proper vitrectomy. The most important step is to do the anti-vitrectomy in such cases. So diluted pilocarpine is important once you're ensuring that the vitreous is taken care of. We don't want the pupil to be too small. We don't want the pupil to be too big as well. So dilute it with pilocarpine and then do this thing. Iridectomy is done with the cutter itself using the IA cut mode with the lowest cutting which is possible in the machine. Just aspirate the small vitreous, small iris, and then make a small nick. And in some situations where the tunnel area is not so clear, I did use an inferior quadrant here to do an iridectomy because the visibility was not great here. So we're going to place the lens in the horizontal 3 to 6 meridian in this plane where you want to actually locate. And I'm using this Clayman forceps. The one trick I would like to share here is that the notch which is there on the haptic, I usually position my flanges of the forceps exactly at that area so that I can localize the position of the notch when it is under the iris. So the lens is pushed against the iris. I'm going to use a blunt cannula. This is a 26G cannula rather than an Sinskuk so that we don't create a hole in the iris. The lens is pushed up and just beside the where potential claw is, I'm going to tap the iris once, and you can see a small puckering which is happening there. I can do it one more time, and just to confirm that the iris is totally engaged, you just move the lens so that the iris also is seen the movement. This ensures that the enclavation is perfect, and now you can go ahead and enclave the other end, because most of the times people are worried that you are going to drop down the lens. But once you're sure that your enclavation is perfect, and that is the way to test whether your enclavation is perfect, then you can always go ahead and do this. So the same thing, you hold the lens in that particular position so that you know where to tap on the iris. So again, the lens is pushed forward, and the blunt cannula ensures that you just tap it down, and you can see this pucker which is happening. And ideally, the enclavation has to be done in the mid periphery or the as much periphery as possible. This ensures or prevents the ovalization of the pupil, which can happen. So this was one case, and so that was it. I think that was the case. I'd like to. I think the time is up. I'd like to stop here, and thank you so much for attention.